Welcome, everybody. Good morning, good afternoon, depending on where you are. Thanks for joining Grand Rounds today, presented by the Department of Psychiatry and Behavioral Sciences. I'm your host. My name is Jed Thompson. I'm the Associate Director of Communications for the department. And while we're waiting for everybody to get logged on today, I'll go over a few of the logistics about our Grand Rounds presentations. You probably heard the announcement when you logged on that this is being recorded. So once we have completed the presentation today, this will be moved over to our YouTube archive. So if you'd like to watch it again, that will be available. We also have an evaluation form. So if you'd like to provide any feedback, you'll see a link for that after the presentation as soon as the webinar closes. So go ahead and use that link if you have anything you'd like to let us know about. We have both the chat and the Q&A feature active today. So if you have anything you'd like to just kind of chat about amongst yourselves, if you have any comments, go ahead and put those in the chat. That will be visible for everyone to see. And if you have any questions, we're going to hopefully have a little bit of time for Q&A at the end. So use that Q&A feature for your questions. I'll have those queued up. And we'll get to those after Dr. Hectors concludes his presentation. FYI, we do not have a presentation next Friday. We're going to take next week off because of Memorial Day weekend, but then we will be returning on May 30th, the following Friday, and we'll be joined that week by Dr. C. Neil Epperson. So please join us for that one. And I'd also like to let you know that today's presentation is one of our Ripley Memorial Lectures in honor of our department's first chair, Dr. Herbert Ripley, who served as our chair from 1949 through 1969. And now I am excited to introduce today's guest, Dr. Stefan Heckers. Dr. Hectors is joining us today from Nashville, Tennessee, where he is the chair of the Psychiatry and Behavioral Sciences Department at Vanderbilt University, a position he has held since 2006. Dr. Heckers attended medical school at the University of Cologne, Germany, and completed his clinical training in psychiatry at the Massachusetts General Hospital in Boston. He was a faculty member at Harvard Medical School from 1997 until 2005, and the director of the Schizophrenia and Bipolar Disorder Program at McLean Hospital from 2003 until 2005. Dr. Hectors studied the neural basis of schizophrenia and bipolar disorder and has explored the mechanism of memory deficits in psychotic patients. He is the recipient of several awards, including the Dr. Paul Jensen Schizophrenia Research Award and the A.E. Bennett Award. He is a member of several editorial boards. He's on the Scientific Council for the Brain and Behavioral Research Foundation, and he served as editor of JAMA Psychiatry for 3 years, from 2015 to 2017. So I've had a great time meeting him today, and I think we're all going to enjoy his presentation. So Dr. Heckers, I will turn it over to you now.
All right. Thank you very much. Can you hear me? And the slide is okay?
Looks good. I hear you fine. Yes.
All right. So I'm asking, are we ready to move? This is a talk about catatonia, but it is also a talk about the bigger concept of schizophrenia. And even bigger beyond that, how do we as psychiatrists arrive at psychiatric diagnoses and how we study the mechanisms of psychiatric illness. I have no conflicts of interest to declare. I receive grant support from the NIH. I hope that by the end of the hour, you will appreciate how we ended up with the diagnosis catatonia and how we currently in the DSM and ICD classify catatonia. I will hopefully educate you about the signs and symptoms and how to diagnose them in a patient with catatonia, and briefly also touch on the current treatment of catatonia. My story begins back in the 1870s in Germany, in a very small town, which is indicated here in that red star called Görlitz, which is now at the border between Poland and Germany. It was in that town that a psychiatrist with the name of Karl Karlbaum was running a private psychiatric hospital. He spent most of his time there taking care of patients, but was also rather prolific in writing about the experiences of those patients, following them typically for several years over the course of their illness. It was in 1874 that he published a monograph about several of his patients, and this is when he coined the term catatonia. You can see here also the German original, and he called catatonia Spannungsirrsein, which would be translated something like tension insanity. This book is translated into English, so if you like to read about his 20 patients that he described, this is now available to the reader in the English language. In this table, you see there are 20 cases shown here in 20 columns. And I've listed here the frequency of the signs and symptoms of catatonia that he himself described. And they're sorted here with mutism and stupor being the most prevalent signs and symptoms of catatonia. I would like to highlight at the bottom that I've also indicated here whether the person by Karlbaum himself was diagnosed to have either depressive or manic symptoms at the time when they were diagnosed with catatonia. And you can see that in 16 out of the 20 cases, he diagnosed the person to be in an episode of either mania or depression. Now, Karlbaum had a significant influence on another German psychiatrist, Emil Kraepelin. But in contrast to the rather important work that Karlbaum published in the 1860s and 1870s, few people know about him and few people know about the impact he had on Emil Kraepelin. All of you, however, have heard about Kraepelin's textbook of psychiatry, which is still a very important book for not only clinical symptomatology, but for our concepts of mental illness, as we currently recognize it in both the DSM and the ICD. You can see here that he had 8 editions of his textbook, starting in the 1880s and finishing at the time of the First World War in the 1910s. And it was really in the textbook that he described 3 syndromes, hebephrenia, catatonia, and dementia paranoides, and grouped them together under one new name, dementia praecox. The textbook started small. He published his first textbook at age 27, but then grew, and you can see here that in the 8th edition, published during his lifetime, it was almost 2,000 pages, published in 4 separate volumes. Indicated here in that stacked bar graph in red, you can see the number of pages devoted to dementia praecox. Well, it might surprise you to know that the first 3 editions of his textbook don't mention dementia praecox because it didn't exist. And it took until the 4th and then 5th edition for Kraepelin to revise his diagnostic schema and come up with a new name and the concept of dementia praecox. The most important contribution that Kraepelin made were not the illnesses and the names that he chose, like manic depressive illness and dementia praecox, which at the end of his career he also recognized with Bleuler's term schizophrenia. He made a more important contribution. He was the first psychiatrist to propose that we as clinicians and researchers can work together to define what he referred to as natural disease units. So look at this graph and look at the left upper corner. Clinicians typically focus on the signs and symptoms and ask questions like, well, if I have one particular clinical feature, is it associated with another clinical feature? Do those features stay stable over time? Do they in any way predict course and outcome of the illness? So that's known as clinical psychiatry. Then you can also ask a neuroscientist, let's say somebody who studies the structure of the human brain, whether in those patients that the clinician describes, we can find abnormalities. In the past, this would be an autopsy and postmortem studies. In current psychiatry, this could be structural or functional MRI or PET scans. And lastly, we can also ask other researchers, let's say geneticists or epidemiologists, whether there's any prediction of genetic markers or risk factors in the environment that allow us to predict the onset of an illness later on in life. And Krappelin's contribution was that he believed that all these different aspects, all of these different features are coming together and converging on the psychiatric illnesses that he referred to as disease units, as something that's out in nature that we can study clinically, pathologically, or using genetics. With that approach, he made an important contribution in the 5th edition and said that these 3 illnesses previously described, dementia praecox, catatonia, and dementia paranoides, actually have the same anatomy and the same etiology. It took him more than 20 years to settle on his own model of the anatomy and the etiology. So I just want to point you to the 8th edition, the most elaborate description of schizophrenia. At that time, he defined already 10 different subtypes, but he believed that all of those clinical subtypes are due to a particular pathology in the upper layers of the cerebral cortex. He had recruited a young psychiatrist who was quite savvy in doing postmortem studies, either with Alzheimer, to pioneer those studies. And he also agreed with some existing research at that time that this could be due to a auto-intoxication, an endocrine factor. And again, at that time, we didn't know about neurotransmitters. But he believed that the pathology that Alzheimer found in the postmortem samples was due to a overstimulation of brain cells that led to a degenerative change over time. So once we start out with the notion that these disease units can be studied clinically, anatomically, and with genetics, it raised some concerns in the mind of other psychiatrists who believed that, yes, we can study the clinical features, and they clearly can be studied, let's say, with statistical techniques. But it is not likely that we will find convergence of clinical features with anatomical observations, genetics, and epidemiology. And Adolf Meyer was one of the primary leaders of the American response to Krappelin's view of psychiatry, and it took really center stage in the 1910s and 1920s. And it took many, many years for the American psychiatry, particularly research community, to return to Krappelin's original view of those disease units. So Krappelin finished his career believing firmly that we can study psychiatric disorders like any other medical condition, like heart disease, like the lesions of the brain. That outcome is the primary validator of psychiatric diagnoses, that we can actually identify not only the cross-sectional psychopathology in the acute phase, but that we can follow individuals over time, and by doing so, separate different illnesses from each other, which of course is the primary idea for his separation of manic depressive illness from schizophrenia. And lastly, he was particularly interested in volition, or the lack of volition, as being a core feature of the severe illness that he called dementia praecox. We have to learn a little bit more about what this meant for Krappelin. Avolition, or volition in general, is described in great detail in Krappelin's textbook, and you can see here a variety of ideas that he had about how can we study the will or the volitional drive of a person. And then you can also go to the next chapter in his textbook and say, which of those features of volition and action are abnormal in schizophrenia? These are the features that Krappelin described as characteristic for schizophrenia, not catatonia. And you will see that there is a tremendous overlap between what we now recognize as catatonia and what Krappelin defined as the core features avolition in dementia praecox. So why is this all important? Why would you want to care about this history of German psychiatry and the attempts of Kraepelin to put together 3 different illnesses under a new name? Well, because it still is the dominant view in both clinical as well as research approaches to psychotic disorders. Robbins and Guzay at the at WashU in St. Louis published this seminal paper in 1970 and reinstated the idea that different approaches, clinical, pathological, genetic approaches, all converge on the same disease units. They refer to them as validators, and you can see here that several of those validators were identical to those that Kraepelin had proposed much earlier in the 1910s. That influence of Kraepelin's view ultimately led to this approach being called a neo-Kraepelinian approach to psychiatry, and it very much shaped the revised versions of the DSM ever since DSM-3. Ken Kendler, who was involved in changing the DSM in the 3rd, 4th, and 5th edition, summarized this and gave an update 20 years after Robbins and Guzay paper. In addition to the original validators, added several more. You can see here they're grouped into antecedent, concurrent, and predictive validators. I've highlighted here in red those 4 validators which were considered to be crucial for any proposal to make changes in the DSM. So in about 2010, when we were actively working on the DSM-5, if there were any proposals to make changes to existing diagnostic categories or introduce new ones, then evidence need to be provided at these 4 levels: family studies or any other genetic studies, diagnostic consistency, a overall functioning of the patients over time, and a response to treatment. If there was not convincing evidence that the diagnoses that were proposed would actually find convergence of those validators, they very likely would not be considered as a new diagnosis. So now we have a new form of looking at Kraepelin's paradigm. So rather than having what I previously showed, clinical features in the left upper corner, and anatomy in the right upper corner, in etiology at the bottom, you now have predictive, concurrent, and antecedent validators, but it is very much identical to Kraepelin's paradigm. One more thing, and then I can let go of this graph of Kraepelin's disease units. You notice that the arrows all point towards the central concept of a disease unit. Now, this is the statistical approach. The statistician would ask for convergent validity across these 3 different domains. And if there is one, then it would be in support of a natural disease unit. But of course, we as clinicians are not so much interested in the statistical properties, but we are much more interested in, now you can see the 2 top arrows going in the opposite direction. We are much more interested in a mechanistic model of how one etiology, think about a brain lesion, think about a genetic risk factor, how one etiological pathway can lead to one abnormality in the brain, which then has a strong correlate in the clinical features. So we are really interested in a flow from etiological pathways through disease mechanisms into clinical features. We then can separate those clinical features, look at the various signs and symptoms of mental illness, and can look at a more sophisticated analysis of those clinical features, either independently from each other, so-called principal component or latent class models, or any kind of a relationship of those clinical features with each other, now referred to as a network analysis. All of those approaches have significantly raised the concern that the Kraepelinian model might not hold, that any of the clinical features that we have described so far have not been validated by an etiological pathway or a disease mechanism that's shared. So what we can do as we are exploring disease mechanisms, we can ask ourselves, should we actually challenge this Kraepelinian concept and choose to separate clinical features that can show convincingly that a previously defined illness, like schizophrenia, can be distinguished and separated using clinical features. And that's what I'm trying to do by looking at catatonia as a feature of illness that can be separated from the larger concept of schizophrenia. Now, it's important to know that most people have an image of catatonia that resembles something like this picture from Kraepelin's textbook. It is not entirely clear how this photograph was created. There is a rumor that I was not able to either verify or falsify that this is actually a group of actors that depicts posturing and catalepsy in a group of individuals with schizophrenia. This is the concept that still is unfortunately shaping how we think about catatonia. Most patients with catatonia do not present with this severe form of posturing and stupor and mutism. Another example, this is an English translation from a Yale psychiatrist from the 1910s of Kraepelin's textbook. It included several photographs like these that show individual patients with a severe form of catatonic posturing. An example of waxy flexibility on the left. And on the right, an example of verbigeration, as it says, a senseless repetition of syllables. One important feature that Kraepelin pointed out, which unfortunately was lost for many years, is that he believed that the patients with catatonic features have a much better outcome than patients with schizophrenia who do not have catatonic features. And it was primarily due to a frequent repeated number of remissions and relapses with an inter-episode recovery of function. Now, Kraepelin was not the only one who held on to the notion that catatonia is a form of schizophrenia. Bleuler, although he came up with a new name, schizophrenia, in contrast to dementia praecox, very much endorsed Kraepelin's concept of these disease units, but he used the word ambivalence rather than catatonia to describe psychomotor features that we now consider to be synonymous with what Kraepelin referred to as catatonic features. So you can see here the 4 A's: association, affect, autism, and ambivalence. And it is really the ambivalence that intrigued Breuer in his patients. Now feed forward to the 1990s. So we've had now a period of more than 50 years of European as well as American psychiatry that took for granted that catatonia is a part of schizophrenia. And it was really one psychiatrist, Max Fink, who over several decades has educated us as psychiatrists, both clinicians as well as researchers, that this might not be the right way of approaching catatonia. And he provided compelling evidence. On the left, you see the information he provided to the DSM-4 committee, arguing for a separation of catatonia from schizophrenia. And on the right, you see his monograph that he published in 2003. This was available to us as we were considering changes in the DSM-5 categories of psychiatric disorders, and was really in the late 2000s and early 2010s that we published several papers on this particular question. Is it important for us to redefine and reclassify catatonia in the DSM? And we were guided by 3 important findings that are pretty solid, for which there's convincing evidence over many decades. First, patients with catatonia are often not recognized, and because the illness is not recognized, the patient gets inappropriately treated. Secondly, a significant number, at least 50%, likely more, of patients who develop clear signs of catatonia do not ultimately get diagnosed with schizophrenia, but primarily with a mood disorder. And third, there is a subset of patients with schizophrenia, maybe 10, maybe 15% of patients who over the course of their life present with clear episodes of catatonia. So it was those three together that made a compelling argument that we should reconsider the classification of catatonia. These are the 12 signs and symptoms that ultimately were included in the redefinition of catatonia in DSM-5. And these are the 4 different clinical scenarios that a clinician could consider to assign the diagnosis catatonia. First, catatonia can be diagnosed in a patient with a primary medical or neurological condition. Secondly, catatonia can be added as a specifier to psychotic disorders. So this is important to know. Until DSM-5, catatonia was a subtype of schizophrenia. So we removed the subtypes, and then we made it possible to assign catatonia as a specifier. But that was identical to what the clinician also can do in a person with a primary mood disorder. So rather than considering catatonia as a subtype, it was defined as a specifier across various conditions, not just psychotic disorders. And lastly, for the first time, a clinician was able to diagnose catatonia not otherwise specified, typically in a setting where little is known about the person. Imagine the emergency room or an acute medical or inpatient unit. And in those situations, a patient can now be diagnosed with catatonia without knowing whether this is due to a medical condition, due to a psychotic disorder, or due to another psychiatric disorder. The DSM-5 stopped there and still held on to a close affiliation of catatonia with psychotic disorders. ICD-11, which came out a couple of years afterwards, took it one step further. Rather than keeping catatonia within the chapter of psychotic disorders, it actually moved it out of the psychotic disorder chapter and elevated it to a new class in and of itself. And this is what the authors argued. Then in the ICD-10, catatonia was included as one of the subtypes and as one of the organic disorders in recognition of the fact that the syndrome of catatonia can occur in association with a variety of mental disorders. A new diagnostic grouping for catatonia at the same hierarchical level as mood disorders, anxiety, and fear-related disorders has been added in the ICD-11. So this is a change that has occurred over the last couple of years, and I predict that there will be further changes. They could go in the same direction as ICD-11 has gone, with elevating it into an independent class, or it could also be with further associations with other psychiatric diagnoses. Now that I've given you kind of a historical review of how we ended up with the diagnosis, how it started with Carl Baum, how for many years, really because of the influence of Kraepelin, we considered catatonia simply as a form of schizophrenia. Now we have started a new era of catatonia research where we are genuinely interested in describing the signs and symptoms of catatonia in a variety of clinical conditions. And therefore, it's important to know, how do we actually diagnose it? This is the gold standard rating scale, the so-called Bush-Francis catatonia rating scale. This is the BFCRS in this table here. This was proposed in the 1990s and is still considered to be the best assessment tool for the many features of catatonia. We took the Bush-Francis catatonia rating scale several years ago and collected more than 300 patients who were screened with this screening instrument for a diagnosis of catatonia. And you can see here that once we actually went through the different criteria, either the criteria for DSM-4 or DSM-5, and also you can see in the middle of this flow diagram that we validated the clinical diagnosis by a response, by either responding to benzodiazepines or ECT. We were able to identify about 200 individuals with catatonia. This is the frequency of signs of the Bush-Francis catatonia rating scale. You can see staring being the most prevalent of all catatonia features, followed closely by stupor and mutism. This is an important detail because it was a change in the DSM-5 steering, which was previously included as a catatonic feature. It did not remain as one of the 12 DSM criteria for catatonia. And you see at the right lower bottom that because of that, about 3 to 4% of the patients in our cohort, those 200 and some patients, would actually not be diagnosed with catatonia because steering was excluded as a criterion. This is the frequency of all of those 23 different features of the Bush-Francis catatonia rating scale. And you can see they can be rated either as absent, 0, or 1, 2, 3. And then you can sort those and you can do statistical analyses. When you do this, you will see that there are at least 3 different components. That means these are signs and symptoms that are hanging together. And you can see in the first group at the top, these are forms of excitement, increased psychomotor behavior. Then the second group is abnormal psychomotor behavior. And the third group is decreased psychomotor behavior. You will see here that the cumulative percent of variance explained by those 3 factors is only 37%. So while these are very significant relationships, and this principal component analysis clearly resulted in a valid finding, we have to acknowledge that the structure of catatonia is not known, and that even with the gold standard assessment, we are not capturing even 50% of the variance in the clinical presentation. So this is a simple resorting and different way of looking at those, but it's the same that I just showed you before. And what we have over the course of several years leaned towards at Vanderbilt is to really separate not only the 3 different psychomotor symptoms, increased, decreased, and abnormal psychomotor activity, but we also help the clinician to think about this in 3 different steps. First, what are the features of catatonia you can diagnose by simply observing the person from a distance? And that's shown in the first column. Then, what are the features of catatonia that you would be able to elicit by talking to the person? It's the middle column. And then third, what are the features that require a physical examination of the person? And you can see that a substantial number of catatonic features can be elicited by simple observation or by talking to the person. We published this in form of a paper a couple of years ago, and I will now take you briefly through these various signs and symptoms of catatonia, because I do not take for granted that all of you interact with patients with catatonia, and you might not even be familiar with some of the terminology, which can be somewhat confusing. So again, there are 3 different groups, 3 psychomotor symptoms that show increased activity, 6 psychomotor symptoms that show decreased activity, and then 15 that are abnormal, qualitatively different, not simply by either increased or decreased activity. And I will take you through each of those, and I will start out with the 3 signs of increased psychomotor behavior: agitation, impulsivity, and combativeness. I'm not going to explain those further because for now I assume that most psychiatrists would have a pretty good understanding of what these 3 terms mean. Decreased activity. Here it's a little bit more complicated. So first, by simple observation, we can diagnose stupor, ambitendency, and staring. So I will define stupor and ambitendency. Stupor is no or markedly reduced psychomotor activity, and there's no activity in relation to the environment. Now, what is required to diagnose stupor? The original definition was stupor needs to be present for at least 1 hour. The person should not move for 1 hour. That's a very high threshold. In most clinical evaluations, even a lack of movement and no response to environmental stimuli for several minutes would be considered sufficient to diagnose stupor. And the tendency is quite different. It's an appearance of being stuck. So the person is able to move, but it is this push and pull, this going forward and backward. A good example is a patient is being asked to leave the room or go from one place to the other, and the person ultimately gets there, but it takes the person several minutes because of this hesitancy in engaging in any kind of movement. Okay, so that's decreased psychomotor behavior by observation. Then we would be able to engage in a conversation, and then we can diagnose both negativism as well as mutism. Negativism would be opposing or not responding to instructions. The textbook example in Bleuler's textbook is Bleuler does morning rounds, tries to engage a person in a conversation, the person doesn't respond, and on the way out of the patient's room, the patient sits up and says, "Wait, Professor Bleuler, I want to talk to you." So the person actually does ultimately respond, but not in the expected way as it would be in a natural setting in a conversation. One step further is the person that would not engage at all in a conversation. Now, similar to stupor, how many minutes, how many hours do need to go by for a person to be diagnosed with either stupor and mutism? And again, the high threshold is 1 hour, but in most clinical settings, even a inability to respond within several minutes would be considered sufficient to diagnose mutism. Okay, so we covered already the two major quantitative abnormalities, either decreased or increased psychomotor behavior. Now we are going to turn to the 15 symptoms that are considered to be qualitatively different. And again, I will start out with observation. Grimacing, I assume most people understand what that means, but how about stereotypy, mannerism, and posturing? I'll keep posturing for later and focus for now on stereotypy and mannerisms. Stereotypy are repetitive, abnormally frequent movements that are not goal-directed. So again, a perfect example is a person rocking back and forth, and repeating this over and over. Mannerisms, on the other hand, are odd circumstantial characters. So I do not know whether you see my image here, but if somebody tries to rearrange their hair and does this over and over, completely out of context, this could be called a manneristic behavior. Stereotypy and mannerisms are some of the core features of catatonia. Okay, so that's observation. In the interview, we can study the echo phenomena. So this is the person who simply repeats the words or repeats the behavior of the interviewer. And then we have these very characteristic signs of catatonia, which are quite rare, but get a lot of attention. And that's verbigoration and automatic obedience. Verbigoration is the continuous, directionless repetition of words, phrases, or sentences. You remember there was a form of verbal verbigoration in form of writing shown in Bleuler's textbook by the repetition of phrases. Automatic obedience is quite rare and is elicited in the Bush-Francis catatonia rating scale by asking the person to do something rather bizarre. The instruction is, please put out your tongue. I want to put a pin through it. This is literally taken straight out of Kraepelin's textbook. I'm not so sure that it's a very valid sign of catatonia, because even after just one examination, the person very much realizes that that is not what the interviewer will do, and very likely will not respond with the automatic obedience. Again, the automatic obedience would be the person sticks out their tongue, not realizing that that, of course, is not what the person should do. Okay, and now the last aspect is the physical examination of abnormal motor behavior. And there we see, again, these very characteristic features of wexiflexibility and catalepsy, which again are quite rare, but made it into the textbook and are still considered to be the characteristic features of catatonia. So wexiflexibility is only diagnosable by touching the person And by realizing that when a person is being asked to move an extremity into a particular position, that there is slight and even resistance, like bending a candle or moving the person's extremity against light resistance. Once the person has been diagnosed with flexibility, the person might then leave the extremity in a particular posture held against gravity. So catalepsy would be the outcome of a physical exam that is often associated with flexibly. In contrast to that, posturing is a spontaneous and active maintenance of posture without a physical exam, without the person actually passively being moved into this particular posture. So taking you back to this photo from Diefendorf's Kraepelin translation. So this actually is not flexibility. This is actually catalepsy, the result of a physical exam where the examiner has put the extremities against gravity. So flexibility requires the physical exam and the muscle tone to be diagnosed. And then posturing, or in this case, catalepsy, would be the outcome of that. And lastly, I need to bother you with some German. And there are two terms, Gegenhalten and Mitgehen, which made it into the Bush-Francis Catatonia rating scale. They're also taken straight from Kraepelin. They are not very common either. But there, again, it is the physical exam that shows resistance to the posturing. This would be the Gegenhalten, or the opposite, the exaggerated movement, where the person follows without any pressure and might even lead the examiner in the movement. Here you have it. Those are all of the signs and symptoms of catatonia. And you can see here, if you count them all together, you come up with 25. But the Bush-Francis Catatonia rating scale only has 23. Well, if you look at this cross there, you can see that in the Bush-Francis Catatonia rating scale, posturing and catalepsy are actually lumped together as one sign. And the two echophenomena, echolalia and echopraxia, are also lumped together under one. So that's why it collapses from 25 to 23. In the asterisk, I show you the 12 signs of catatonia that made it into the DSM. All right, so I hope that that gives you a kind of a roadmap to the approach. It takes about 5 to 10 minutes to do a high quality catatonia exam, but I want to just remind people that even by observation and by talking to the person without even doing a physical exam, you are able to diagnose a significant number of catatonic features. So why would the person present with those? So I need to, kind of familiarize yourself again with this cortico-thalamo or cortico-striato-thalamo-cortical loop, which governs motor behavior. M1 in this diagram here is the primary motor cortex. And based on neuroimaging studies over the last 20 years, there's increasing evidence that an abnormality of the premotor regions, the supplemental motor area and the pre-supplemental motor area, leads through this striato-thalamo-cortical loop to an increased inhibition of the primary motor cortex, which then could lead to the downstream effect of people being stuporous, mute, and having abnormal psychomotor behavior. But we have learned very recently that our concept of the motor cortex might not be absolutely correct. On the left side, you see the homunculus that we have been teaching our medical students for many, many years, that the motor strip, M1, is organized on the precentral gyrus in the form of a homunculus with a somatotopic organization. So each region of M1 codes for one particular part of the muscle groups. Most recently, we have now learned, primarily with neuroimaging studies in healthy individuals, that there are so-called inter-effector regions that are interposed between the primary motor regions. So even on the motor strip itself, we have integration of rather complex psychomotor behavior. And if that turns out to be the case for the human motor system, it could actually mean that the organization of psychomotor behavior and the localization of catatonia features might not be in the pre and supplementary motor areas, but also in the motor strip itself. Briefly, if there really is an abnormality in this motor circuit, what are the neurotransmitter systems that are involved in giving rise to these abnormal connectivity patterns? And this particular review by Hrčák and colleagues is particularly helpful. It highlights the 4 different patterns that people have described: abnormalities in GABA, either decrease or increase, abnormalities in the glutamatergic systems, and abnormality in the dopaminergic system. For now, I will just highlight 2 of them. First, the decrease of activity at the GABA-A receptor. So these are ion channels that allow chloride to go into the cell, which is the major way of inhibiting neural activity. We know that a modulation of GABA-A receptors through benzodiazepines like lorazepam is the most effective chemical intervention in the treatment of catatonia. So while we do not know whether there is a primary deficit of GABA-A receptors, the imaging studies have not been conclusive. There are very few, and those that have tried to map it out have not shown convincing evidence. Despite that, there is compelling evidence that modulating the GABA-A receptor in an agonistic way is the most effective treatment. Now, on the flip side, dopamine, we know that the blockade of dopamine, primarily dopamine D2 receptors, is leading to a syndrome often referred to as neuroleptic malignant syndrome, which can be considered a form of malignant catatonia. Again, induced by a blockade of dopamine receptors. Lastly, I want to also highlight that there is emerging evidence that abnormalities at the glutamate NMDA receptors might be a mechanistic pathway in catatonia. And this has to do primarily with the very compelling association of NMDA receptor autoantibody encephalitis leading to an acute encephalopathy with catatonic features. This particular paper gives you a very detailed review of all of the different treatment protocols. And again, it highlights the unique efficacy of benzodiazepines in the acute treatment and also the very compelling evidence for ECT as the most effective treatment of catatonia. We summarize this in a recent review article, and I want to finish my presentation with a couple of slides taken from this review paper. What we wanted to do in this paper is to really educate the clinicians in 3 different settings: the clinician in the emergency room, the clinician on the medical floors, and the clinician in the psychiatric setting. So let's start out with the emergency room. It is not known how prevalent catatonia is. The prevalence data on emergency room settings vary quite a bit, from less than 5% to almost 15%. It does require I would say, educated clinician to recognize catatonia when it occurs and not to confuse it with other changes in mental state. The important detail here is that the person in the emergency room should take advantage of the so-called lorazepam challenge listed here at the bottom. So it is not simply the administration of a benzodiazepine in either IM, PO, or IV form, but rather the recording of the severity of catatonia using a rating scale like the Bush-Francis Catatonia rating scale. Then the administration of 2 milligrams of Ativan could be done in any way. Most often it would be done IM in the emergency room, but also can be done PO or IV. And then the recording of a response within 10 minutes of the lorazepam challenge. And if the person does not improve, a re-challenge, again with 2 milligrams of Ativan, including additional exposures to the same dose as long as the person is able to tolerate it without sedation, the so-called therapeutic window for benzodiazepines. This is a unique challenge in the emergency room, or a unique opportunity in the emergency room, to diagnose catatonia and separate it from several other conditions that might look very similar: acute psychosis, intoxication with various drugs, neuroleptic malignant syndrome, which would not respond to the lorazepam challenge in the same way. And the second very important feature, in addition to the challenge, the clinician also should be very careful and not to treat a person with a dopamine antagonist, which would be the typical treatment for a person in acute psychosis. Okay. I just want to highlight that the recent characterization of autoantibody encephalitis cases has mapped out this course of the illness and has shown that in this relatively early stage of the illness, a lot of patients have a severe form of encephalopathy that is often associated with features of catatonia. This was nicely captured in the book Brain on Fire by a New York journalist that also ultimately was made into a movie. And she describes in excruciating detail how long it took for her to be accurately diagnosed with severe forms of catatonia, accurately diagnosed to have a form of autoantibody encephalitis. Okay, the second scenario, briefly, the medical unit where patients can be diagnosed with catatonia in a variety of medical conditions. The primary differential diagnosis here is delirium and epilepsy. My colleague, Joellen Wilson here at Vanderbilt, has been one of the pioneers to show very convincingly that catatonia and delirium can co-occur, particularly in an intensive care unit setting. And if so, that it then also changes the treatment of delirium, where we typically avoid benzodiazepines, but very likely have to consider it earlier in the treatment if there are also additional features of catatonia. But the majority of patients that get diagnosed with catatonia will still be seen in a psychiatric setting. So this could be in a psychiatric emergency room or in a psychiatric inpatient unit. It is also possible to diagnose catatonia in the outpatient setting, but if that is the case, it would typically be a milder form and very likely a form of a protracted form of catatonia or a relapsing form of catatonia. And as I mentioned at the beginning, the majority of patients who get diagnosed with catatonia have either a mood disorder, a psychotic disorder, or, and this is increasingly known now, a neurodevelopmental disorder. The treatments, as I mentioned, is primarily benzodiazepines and electroconvulsive therapy. They are the gold standards. Once those have exhausted, additional secondary lines of treatment include valproic acid, often also very helpful after treatment with a benzodiazepine before discharge to the outpatient setting. A lot of patients get converted from benzodiazepines to valproic acid. Memantine and amantadine can be also given, although the efficacy is clearly not at the same level as benzodiazepines and ECT. There are initial clinical trials to also establish rTMS as an alternative to ECT. And that's the summary of the clinical presentation of catatonia, our evolving diagnostic assessment and grouping of catatonia, and a couple of ideas about disease mechanisms. I want to finish with just one final note. While catatonia for many years has been considered a severe form of mental illness and has been linked with a severe form of schizophrenia, it often occurs in a much milder setting, and if so, also requires a different approach that is not only relying on psychopharmacology and ECT, but also requires a very thoughtful psychotherapeutic approach. And we try to capture this in this particular Viewpoint article. And lastly, for those who like to read beyond the technical literature of clinical psychiatry, you might want to pick up Herman Melville's Bartleby the Scrivener, published in 1853, and maybe the most compelling description of a severe form of malignant catatonia that ultimately led to the person dying because he stopped eating and ultimately perished away. Melville captured catatonia with these words: I might give alms to his body, but his body did not pain him. It was his soul that suffered, and his soul I could not reach. Bartleby, the scrivener, died by simply repeating in the form of a reverberation one single phrase. I would prefer not to. A classical presentation of avolition and negativism described by Merleau. And that gets me to the end of my talk, and I have a couple of minutes to take any questions, if there are some.
Yeah, thank you very much for that. And it's right. That's right. We have about 5 more minutes left with Dr. Heckers. So folks at home, if any questions came up, go ahead and type those into the Q&A feature. And while we...
Okay, I see it already. So I was able to figure out the first question. Only 10 minutes before repeat lorazepam. You can wait, but typically it would be within 10 to 30 minutes. So the Bush-Francis catatonia, I think the instructions there would be within 30 minutes. It's not so much that we have to wait, but rather that we need to allow the person to be tested for a change in symptomatology, meaning we have to assess before and after the administration. The efficacy of benzodiazepines is within minutes, not all too different in how the neurologists would treat status epilepticus with intravenous benzodiazepines. So we typically see a loosening, a weakening of posturing, an engagement of the person within several minutes. But again, to be more cautious, you can wait 30 minutes. And then if the person has not responded, try another 2 milligrams of Ativan. All right, there's another question. What are the specific features of catatonic presentation in autism spectrum versus psychotic disorders? There's a colleague here at Vanderbilt, Josh Smith, who has become an expert on this. He actually feels so strongly about the different features that he even proposes the Kenner rating scale to be used in an individual with a neurodevelopmental disorder. It is picking up a little bit more of the motor features and less of the cognitive features that we might see in the Bush-Francis catatonia rating scale. So I would strongly recommend that a child psychiatrist who wants to really pick up catatonia features in a patient with a neurodevelopmental disorder, they should really look into Kenner's rating scale. Okay.
Yeah, now we have a lot coming in pretty quick here. So how about this one? Do you have any comments as to whether there have been an increase in prevalence over time, particularly in adolescents?
I don't think so. I don't think that there is an increase in prevalence over time, but I can tell you that there is a significant increase in the diagnosis because people are now more educated in actually seeing catatonia when it actually is in front of them. This is, even after having done this for decades, a remarkably common scenario that a person is being called something else, responding to internal stimuli, thought blocking, not willing to move, so-called volitional behavior. All of those are often used to describe clear features of catatonia, particularly the milder forms like ambivalence or negativism. So I don't think there's necessarily an increase of the prevalence, but clearly a greater ability to diagnose it. Yeah, there is an important question. I have a slide on this, so maybe I can advance to this. There is a significant challenge for clinicians who see catatonia in the psychiatric setting, which is the occurrence of catatonia features in a person who clearly is in the throes of a psychotic episode, typically schizophrenia. Here, the very important message is that a person with a psychotic disorder who also presents with catatonia will respond to benzodiazepines in the treatment of the catatonic features, but will not respond to this treatment in the form of changes in the psychotic features. So additional disorganization of thought rather than behavior, paranoia, hallucinations need to then be treated with an antipsychotic. So what we typically do, if a person with, let's say, an established psychotic disorder also has a psychotic episode with catatonic features, we start out with a benzodiazepine first over the first 24 hours, maybe 48 hours, withhold the antipsychotics first to see that the catatonia is melting under the treatment with benzodiazepines, and then reinstate or start for the first time an antipsychotic. And that thoughtful reintroduction of an antipsychotic, looking again for the worsening of catatonic features, is often very, very relevant and necessary for the treatment of the combined presentation of psychosis and catatonia.
All right, well, that brings us to 1 o'clock. So I think we'll go ahead and wrap it up here. So Dr. Heckers, thank you so much for being here today. We can tell by the amount of questions that have come here at the end that this was a very interesting talk for a lot of people. So appreciate you being here, sharing this information with us.
All
Everyone
right.
online, yeah, thanks for this big crowd.
Thank you. All the best to Seattle. Yeah. All right. Okay. Bye-bye.
All right. See you in a couple of weeks, everybody. Thank you.